has now, the past 3 decades, it's changed. So now we get up to maybe the 50s before people really begin to lose teeth in any great number. And you're probably into your 60s before you really see the completely edentulous numbers coming through. But what will be such a big challenge for us is that it could well be that you are in your mid-80s before you lose the last teeth. So very successful treatment protocols perhaps have maintained a limited dentition up to that age, but then suddenly at a point in life where your ability to adapt to something new and your ability to look after it is now going downhill, at the same time as you now face this transition and that huge challenge of getting on with something that is not your own. And you may also be medically compromised at that point, or you may have been taking the modern medicine now for a number of years, which means that it's not appropriate for you perhaps to have treatment like implant treatment. I think we've been wondering whether the tendency will be that we will get more edentulous people rather than less, or how that will be influenced by the oral hygiene as it improves, etc. And I think maybe I've answered that by saying that as this will happen much later, even if oral hygiene has improved, people might not be able to look after it at that point. And it will just happen later, and then people will live longer, because definitely the trend is, of course, to increase life expectancy. Yeah, there's definitely still there's a wide range of treatment options open now in the scope of what you can do for an edentulous patient. I suppose it's still the reality for most edentulous patients to have something conventional. Implant therapy hasn't penetrated around the world to the point where edentulous patients perhaps can either afford or that they have access to implant-assisted options. And there is a problem there, because I think also the profession is not rating removable prosthetics high enough in undergraduate teaching, and then dentists graduate and they don't have the required experience maybe in carrying out and providing removable prosthesis. And then even as you then move into maybe something that's implant assisted, and after all we have enough both scientific and clinical validation to say that with patient outcomes as well, that the first choice standard of care ought to be prosthesis that's retained by at least 2 implants in the mandible and the lower jaw. But I don't know if it's realistic yet. I'm also not quite sure that the dentist is yet able or is maintaining the skills to provide this. So I think that is a really big challenge for us. I would have thought that what we've got now is from that level of the conventional prosthesis through the first choice or minimum standard of care of looking after the mandible to sort of put it on par with the upper jaw, with the maxilla, and then upwards as you go through the range of removable options and into fixed options. I think we're very well covered now. What would be good to see is a transition where you turn it around and you say we're not looking at individual solutions and techniques that drives what people have. We're looking at the treatment outcome and what actually suits best the individual patient. So I think as a specialist, what's important to me is not that I am capable of supplying X, Y, and Z options. What's really important is that I'm able to find out what's the most appropriate for a given patient and then provide that. And that depends on a whole lot of factors, and of course not just on the treatment solutions that are available. Patients' expectations, I mean, clearly with the media and with internet and with knowledge, and people come in and they would like something. I often hear, for instance, it could be that the wife comes in and it's suitable for her to have one solution for both upper and lower jaw, but it might not be suitable for the husband to have exactly the same. And then you have to manage patient expectations. But patients certainly come now with much more knowledge, general knowledge, and pictures of how they'd like to look at the end as well. And those pictures may not resemble them in any way, so of course the challenges go up and up and up. But I think there's still a very large group of patients who would just like to be comfortable. They'd just like to be able to communicate, not to cover their mouth, not to disguise their teeth as they go about their daily life. And I think that in itself, that's a huge challenge. But patients are becoming more aware, and they will definitely be coming, and maybe that will also drive the profession to have to provide a wider range of of treatments. Yes, I think if you are edentulous, I think what's first and foremost important to you is the autonomy to go about your life without being conscious of this really potentially enormous handicap that you have, that you also would feel very shy and reticent to share the details with others. As a removable orthodontist, it's very rare that somebody recommends you to someone else, because actually what they want is to maintain complete dental privacy. So if they can leave you and to the point where nobody realizes what's happened in their mouth, then they'd like to keep it that way.
Right.
I think when you look at edentulous solutions and you look at who should provide them, and is this actually a specialized area or not, I think at the area, at the lower end of the scale, or the simpler end of the scale, where you are just providing a prosthesis and maybe putting in tube implants and some retentive option for that, that has to stay in mainstream. That's where the main number of patients are. And I think it is very difficult to restore an edentulous patient, because it is a full mouth rehabilitation by default, by definition, because you are providing all the teeth again. But at the less invasive end of the scale, I think we all need to be able to do that. We really do need to preserve the skills to do that. When you move up the scale and you move into more advanced, maybe patient cases, because also the surgery gets more invasive and more complex, and if you move into the big fixed restorations and full arch, etc., yes, then it becomes more specialized, and you really ought to have that specialist knowledge. But at this simpler end, we all need to be able to provide patients with that, because it's such a basic human right almost, that you have something in your mouth that allows you to not be conscious of this handicap of having lost your teeth.